What is the diagnosis? A. Pericardial cyst. B. Right atrial enlargement. C. Aortic aneurysm. D. Mediastinal mass. Correct answer C. Aortic aneurysm. Other conditions do come in the differential diagnosis of a similar appearance. In this case, previous X-rays were available to support the diagnosis. Asymmetric VSD closure device has been designed for the closure of A. Subpulmonic ventricular septal defect, B. Perimembranous ventricular septal defect, C. Muscular ventricular septal defect, D. Inlet ventricular septal defect. Correct answer B. Perimembranous ventricular septal defect. Asymmetric VSD closure device has a shorter flange on the aortic side than the apical side to prevent impingement on the aortic valve and the conduction system. The asymmetric device needs only 2 mm of tissue on the aortic rim to hold, while other devices need about 5 mm of tissue all around. Symmetric devices are meant for muscular VSD closure as there is adequate tissue all around to hold the device without impinging on any important structure. If that device is used in the perimembranous location, it can affect function of the aortic valve and the conduction system. What device is seen on this chest X-ray? A. Pacemaker, B. Implantable loop recorder, C. Implantable cardioverter defibrillator, D. None of the above. Correct answer C. Implantable cardioverter defibrillator. Implantable defibrillator high voltage coils on chest X-ray PA view. The ICD generator is seen in the left infraclavicular region. The lead is coursing through the left subclavian vein into the left brachiocephalic vein and hence into the superior vena cava. In this region, the high voltage coil is seen. This ECG is suggestive of A. Wenckebach phenomenon, B. Ashman phenomenon, C. Katz-Wachtel phenomenon, D. None of the above. Correct answer C. Katz-Wachtel phenomenon. The Katz-Wachtel sign is tall diphasic RS complexes at least 50 mm in height in lead V2, V3 or V4, mid-precordial leads. Original description by Katz and Wachtel was published in 1937. The sign has been described in ventricular septal defect with biventricular hypertrophy in children. It can be seen with isolated ventricular septal defect as well as complex ventricular septal defect. In fact, the circulation article cited is on complete transposition of the great vessels. What is the rhythm? A. Sinus bradycardia, B. idioventricular rhythm, C. Junctional rhythm, D. None of the above. Correct answer C. Junctional rhythm. Regular narrow QRS rhythm at 60 per minute is seen with normal QRS and T waves. P waves are not seen. The first possibility is a junctional rhythm. In a mid-junctional rhythm, the P waves will be within the QRS and not visible. In a high junctional rhythm, the P waves will be inverted in leads 2, 3 and AVF, occurring with a short PR interval. In low junctional rhythm, the P waves are inverted in these same leads but will occur after the QRS with a short RP interval. In mid-junctional and low junctional rhythm, there will be regular cannon waves in the jugular venous pulse as the atrial contraction is during ventricular systole when the AV valves are closed, resulting in backflow of blood from right atrium to the superior vena cava. A slow and regular rhythm with absent P waves can also occur in atrial paralysis due to severe hyperkalemia or due to any other reason. But in this case, hyperkalemia is unlikely as the T waves are quite normal in amplitude. Moreover, the QRS can also become wide in severe hyperkalemia. Atrial standstill can rarely occur as an idiopathic disorder in some muscular dystrophies and following radiofrequency ablation procedures in the right atrium. A third possibility for a slow, regular, narrow QRS rhythm with absent P waves is fine atrial fibrillation with complete heart block. In that situation, the QRS is regular because it is initiated by a junctional focus and not by the irregularly conducted fibrillary waves. It is unlikely that all the 12 leads will not pick up the fibrillary waves in fine atrial fibrillation. In this particular case, this rhythm was transiently seen after conversion of supraventricular tachycardia with intravenous verapamil. Normal sinus rhythm was recorded after some time. Which of the following is not an endothelium-derived relaxing factor? A. Endothelium-derived hyperpolarizing factor. B. Nitric oxide. C. Prostacyclin. D. Thromboxane A2. Correct answer D. Thromboxane A2. Endothelium-derived hyperpolarizing factor, nitric oxide and prostacyclin are the three endothelium-derived relaxing factors. Thromboxane A2 is produced by activated platelets. It is a vasoconstrictor and promotes thrombosis. Patient prosthesis mismatch is most likely to occur with A. Aortic valve replacement, B. mitral valve replacement, C. pulmonary valve replacement, D. tricuspid valve replacement. Correct answer A. aortic valve replacement. An effective orifice area less than 0.7 square centimeter per square meter of body surface area for the aortic valve is taken as patient prosthesis mismatch in case of aortic valve replacement. This is more likely to occur when the replacement is done in the case of severe aortic stenosis with a small aortic annulus. Please don't forget to subscribe to this channel for future updates and click on the bell icon for all updates. Thank you.